my great pleasure to now introduce you to our panel for today's session. I'm going to start by asking them each to come up. So first up, can I invite Professor Lisa Nissen. Lisa is Program Director for Health Workforce Optimisation at the Centre for Business and Economics of Health, University of Queensland. She's been a health practitioner, leader, educator, researcher and implementation scientist in Australia for more than 25 years. Lisa's research has led to major health system change, including the introduction of immunisation services by pharmacists throughout Australia and implementation of prescribing competencies and frameworks for health professionals nationally. So it's no surprise why we invited her here today. Her focus is on health service optimisation, including scope of practice and quality use of medicines. She's a fellow of both the Society of Hospital Pharmacists of Australia and the Pharmaceutical Society of Australia. I would also like to welcome Adjunct Associate Professor Paul Burgess. Paul has 15 years of experience as a dual qualified public health physician and rural general practitioner, and is the Acting Director of Population and Digital Health with the Northern Territory Department of Health. He has lived and worked in the Northern Territory for more than 2 decades and has been a champion of quality improvement, health reform and Aboriginal workforce development. His clinical and research interests include value-based healthcare, co-designing care models with Aboriginal health service users, healthcare financing, remote medicine, integrated care delivery and health equity. Next, can I invite Yasmin King to the stage. Yasmin is the CEO of Skills IQ, an organisation responsible for supporting training product development in the community services and health sectors and some areas of government. She's an experienced negotiator and mediator, having led major commercial and corporate negotiations. Combined with her previous experience as the inaugural New South Wales Small Business Commissioner and as Associate Commissioner for the Australian Competition and Consumer Commission, Yasmin has a deep understanding of the challenges of negotiating at the boundary between government and the private sector. Yasmin is a current member of the adjunct faculty at AGSM, where she teaches negotiation skills as part of the Women in Leadership program. And finally, Professor Michael Pervan. With over 25 years of experience as a senior executive in human and community services sectors, Michael Pervan has both operated hospitals and health services and contributed to the policies under which they operate at the national level. He has been at the forefront of major system reforms in health services, child protection and youth justice across 2 jurisdictions, and has contributed to national reform initiatives and policy development, including the 5th National Mental Health and Suicide Prevention Plan. Michael is a Churchill Fellow and a past member of the Australian Health Ministers Advisory Council, of which he was chair from 2018 to 2019. So it is an incredible panel, and I will also invite Michael Brennan to join them as well up on the stage. We're going to kick off though by first throwing back to the audience. What I would like to hear from people in the audience is, what does an integrated workforce look like to you? Workforce is our theme today. Would anyone like to start by sharing what they think before we throw to the panel and get them to share their views?
From Sarah, it would be multidisciplinary, working to top of scope, but also across the breadth of scope, and where the edges are somewhat fuzzy, that enable a movement across the different disciplines.
I'm Lauren from the Royal Flying Doctors, and I think one of the ways we often talk about this is from a patient perspective, given places where a lot of our patients come from, that seeking care is seamless through different disciplines and settings, and that's not always the case at the moment.
Thanks. Hi, I'm Robert. I'm from the Commonwealth Health Department, particularly looking at dementia. And I guess very similar to Lauren, when we talk to people living with dementia, the thing they describe after diagnosis is feeling lost, despite the fact that there's a whole lot of health professions there to help them.
Would anyone else like to have a final? Oh, Louise.
I think it's where the patient's needs are met in a way that the patient doesn't have to stitch the workforce together.
Excellent. Okay, well, that's not your only chance to speak, but we are going to hand over to our panellists now, and I'm just going to start by asking them each a question. I'm going to start with you, Lisa. So, could you just briefly introduce your interest in this area and speak to a key learning you've identified through your experience with COVID vaccination?
Thank Thank you. My background obviously is in pharmacy, so it's good that, thank you for talking about pharmacy in the introduction today. But I've spent probably the last couple of decades as an educator as well of health professionals, so I like the idea of learning together and working together. And more recently I've spent, well not more recently now, I say 2 decades, working on trying to get people to work to top of scope, but not necessarily identifying that by profession and hat that people wear, but more the skill that people bring to the table for a service and for patients. So it's way up my my alley to be talking about this, and many of the comments already today have resonated with what I'm working on every day. I think as a specific sort of example that I could speak to recently, I was seconded to the vaccine task force with Queensland Health to work with Jeanette Young's team, which was an incredible adventure, but a great opportunity. And I think that was mostly because of the work we've been able to do through bringing in pharmacists, vaccination, what feels like a long time ago, but not that long beforehand, to prepare for a pandemic by having another workforce with skills that they could bring to the table to give vaccines. But what we were able to do from that was say, well, what are the skills that are required to deliver vaccines in our vaccine hubs? So when I was writing the regulation or our code for COVID at the time, we were sitting down and going, okay, well, what's in our health workforce that we have available to us that have competencies and skills already that will set them up to be appropriately identifying an arm and then being able to stick something in it. And then if we were going to get them to, so physio came to mind, speech, because they do some anatomy, occupational therapy, like the list went ex-phys, like the list went on, and then very quickly we had a large list of people, not just nurses and pharmacists, who were able to contribute skill to the table. But then what did we have to add to that? Within a governance model of our mass vax clinics, which is what we were mostly talking about, we needed a workforce, we needed it fast, and we knew we had a student workforce as well in all of those professions, and how could we do that? So we thought, well, what is the skill that they need to be able to do? In these clinics, they need to be able to administer a vaccine in a construct and governance that we have in our mass vax clinic. So we taught them to do that. We taught all sorts of health professions to give vaccines. And that was the workforce we utilised to do that. So it was about the skill that was required, the governance framework that would support that. So sure, if those people had a vasovagal or they had an anaphylactic reaction, we had paramedics, we had medical staff, we had IPNs who could lean in and do that. But these people could administer and recognise the signs that it was going wrong, raise the alarm and bring in the appropriate people with the next level of skill. And that's what we need to do for the workforce. And the work that we did in pharmacy vaccination, how we brought that in, we used the national framework, with the national competency framework. We said pharmacists are just going to do what everybody else does. We're not asking for something different, we're going to do the same. And I think that's where we need to go. It's the skill you bring, not the hat you wear. And it's about the patients and what the system requires. So I think that's my best example that I've had recently. And it helped us to roll out a massive vaccination program really quickly.
Thanks, Lisa. I could ask a lot of questions about the experience that's come over the decades, but I might save that for the audience until we've got through all of the panellists. Paul, we're going to go to you next. Can you introduce your interest in this area and speak to the key learning that you've made through your experience, whether it be through cardiovascular disease prevention in remote communities?
Yes, thanks very much for the invite. And John Deeble, of course, was no stranger to the Northern Territory. He spent a lot of time in the Territory and did remark that the Medicare system wasn't fit for the Northern Territory, given our remote service models. So being a little bit of a challenging jurisdiction to provide healthcare, we also have a specific lens when it comes to particularly our rural and remote communities and First Nations, which are predominantly in our rural and remote settings. That integration is going to look a little bit different for us, as it should. It should always match the service population. In the Northern Territory, cardiovascular disease is the #1 killer, and as a clinician, I'm still troubled by the young people in their 20s who I failed to resuscitate from their cardiovascular events. And that's the reality for a lot of us remote GPs in the Northern Territory. It's a very challenging context. In the early 2000s, we had a red hot go about this, and we tried to put in systems of care. We looked at world best practice and quality improvement, referred to by Michael in the Productivity Commission report about our chronic disease program, and we knocked it out of the park in terms of process. If you were attending one of our clinics, you were 14 times more likely to have your cardiovascular risk assessed than anywhere else in the country, and also being on a care plan and appropriate medications. So we were feeling pretty good at that stage, and then we looked at the outcomes. No change. What are we doing wrong? And to answer that question, we went back to communities and we asked them, what does high quality care look like? Because obviously doing stuff to you with evidence-based guidelines is not enough. And it was really salient example and humbling, and also incredibly important for us to hear the voice of First Nations consumers in their first language about what they saw high quality care to be. And lo and behold, this goes to what they value instead of the value-based healthcare conversation. What our First Nations consumers and remote communities appreciate is a relationship, a long-term relationship to manage their chronic condition. And given our non-Aboriginal staff turnover of 148% per annum pre-COVID, you could add a zero to that now. That ability to form relationship can only be through First Nations clinicians themselves. And so that brings us to a point now where what does the integration workforce look like for us in First Nations? What will be the communities? What will be the glue that keeps our system together and increases productivity? And it has to be us to regrow our Aboriginal clinical workforce. And there's been a series of policy missteps over the last 2 decades that have decimated our Aboriginal workforce. In 1995, when I started in the Territory, there were 450 Aboriginal health workers. They're now less than 30. So there's some really big challenges for us to regrow that clinical workforce. And we've heard very clearly from community that if you want to integrate care, if you want us to engage with care, it has to be with our people.
Thanks so much.
Well, thank you.
Thanks, Paul. I will also be coming back to you. Yasmin, could you talk to us about your interest in this area and speak to us about one of the key challenges we've had to overcome to ensure that the healthcare workforce is able to move away from the current siloed approach to their scope of practice?
I wish I could give you a positive example. I think one of the challenges that we see, and my interest is in the, if you like, the vocational workforce, is that if I use the example of there's been a medical assistant qualification which was written in 2015 and which is basically designed to support primary practitioners in basically doing a lot of the administrative and documentation of patient history to enable basically GPs to operate at their scope of practice. That qualification's been in existence since 2015, and there have been 75 people who have done it in the last year. Have completed it. 700 people enrolled last year, but 75 people completed it. And if you have to ask the question why, it's because basically the funding isn't there for those people to basically be employed. And I mean, you know, my interest in value-based healthcare is because I think if you're going to truly have a system which has everyone operating at their scope of practice, that means across the whole value chain, and really utilising people who have got skills but don't have the same sort of status qualifications that are a lot more expensive, to enable basically the right care for people on the ground. And particularly in Australia, where we've got so many thin markets, where like in rural and regional areas, if we don't look at how we can better utilise people at all scopes of their practice, then, you know, the inequity that was talked about by someone during Michael's presentation is just going to be an increasing feature of our system. So,
Thank you, Yasmin. It's also a great example. Michael, we're going to finish with you in the panel summaries. Can you introduce your interest in this area and speak to what you see as the most important elements of a successful and sustainable approach to developing the workforce we need when and where consumers need it?
Thank you. So it was 2008 and our freshly minted new Prime Minister was driving a discussion nationally around health reform. He came to the hospital I was running, I think 3, maybe 4 times in the course of a year. The current health minister tagged along a couple of times and engaged direct with staff, with volunteers, with everyone. And that led to the working groups, the national work through RMAC, through other bodies to develop what became ABF and led to the 2011 legislation, the IPA, the National Health Performance Authority, which seems to have disappeared, and of course the Safety and Quality Commission. Now, around that time, work that a colleague in Tasmania was doing for me indicated that we had around 1% of the population, 5,000 Tasmanians, moving through our health system, so not the whole health system, just the state-run health system, who had 5 or more diagnosed chronic conditions. That 1% were accounting for 18.5% of our health spend. And my concern at that time, with where we were going with ABF and just the whole idea of episode-based funding, wasn't going to get them a good result or a better result. Because in effect, and I've used this when I've been trying to explain it to non-health people, you're asking someone to go to Southern Cross Station and get on 5 trains in 5 directions at the same time. And we had very robust discussions with Stephen Duckett, who said, well, swings and roundabouts will take care of that. I still don't really understand what he means by that. Maybe it's just to keep people busy going around on the roundabout. But the bottom line is we had a significant cohort of Tasmanians who were costing a lot of money and having a really poor life because of it. Many of them sitting for hours on end queuing for outpatient clinics and all sorts of things. We didn't have an enabling framework that enabled us to share patient information with our primary health network, and we have the advantage of having one PHN and one local hospital network. And yet we still couldn't sit around a table and say, here's this group of patients, what are we going to do to manage them better? All along this journey, there's been little signals, little snippets to keep me interested, engaged and passionate about pursuing this. One of them was as simple as a rehab locum that we had from Wichita Falls, Texas, of all places. And he came in and emptied a rehab ward that had sub-patients who'd been living in our teaching hospital for, I think the record holder was 5 years. She had bought her own wardrobe and repainted her own room. And her clinicians wouldn't discharge her because she was terrified of leaving the hospital. She was quite physically able to do it. She was just too scared to. In came Farouk, and he did what he did in Wichita Falls, which a managed care organisation made him do, which was he wrote on a simple piece of paper a list of rehab outcomes, including going home on reverse respite, if you like, and a column for him to sign off and a column for her to sign off. And he just worked her through those goals, and 10 days later she was gone with her wardrobe. But the idea of getting a patient engaged in setting their own outcomes for care has been something that has stuck with me for 12 years. And then along the way, other great clinicians. We've got, she was a nurse, she's now a nurse practitioner, who runs the John Morris Diabetes Clinic at Launceston General. And the patient reported outcomes there were very poor. They were constantly coming in via the emergency department. It was pretty depressing. And she very courageously got all the patients into a room with lots of butcher's paper and said, optimistically, tell me what's great about our service. That didn't go so well for us. So then she said, all right, tell me what we're doing wrong. And over the next 6 weeks, totally redesigned that service and how patients interact with it including what sort of home monitoring they use, how it's reported, who it's reported to, how they get feedback for that data, all of those little things that actually mean that they have control over their lives so that they're no longer a transport system for their diabetes. They're a person that just happens to have the condition. And so there are examples, and we heard from Gillian earlier, there are heaps of them in New South Wales, and Michael cited a few, where we've had fantastic leadership pushing against the tide because we don't have authorising frameworks at a system level that enable these things to happen. You either need really brave people who are really passionate about it, or you need a minister who's going to put her hands around Treasury's neck and say, no, I am going to put this money to one side and it will pay for innovation and we will report on it. Unfortunately, ministers retire and new ministers come in and just want to get those ramping stories off the front page or the waitlist stories and just move the money into things that attract media attention and make them unpopular. In terms of the workforce, and we've heard it coming through in all sorts of ways. In fact, we just heard it about vaccination. What is the outcome we're trying to achieve? What are the skills we need to deliver that outcome? And how do we design that with the patients at the table? Not go and consult with them, not have a rep, but how do we co-design that? Because then we know it's going to work. And then it's a matter of monitoring and reporting and making sure that you make the adjustments along the way, as you inevitably have to do, to keep it successful. But it all starts with the model of care, the outcome you're trying to get to. Don Berwick in the IHI coined the whole phrase, every system's perfectly designed to get the results it gets. So if they're bad results, it's because the system's designed to produce those. Unfortunately, he never put the next bit of the obvious sentence on, which is, so the only way you're going to get better or different results is to change the system. At the moment, we're trying to bolt great ideas onto a system that doesn't support them. So the next phase is to put, it's either a redesign of the whole system or to identify the patients that need that different approach and design a new approach for them.
Thank you all. So, Michael, when you started your throughout your whole presentation, you gave numerous examples of innovation. We've just heard numerous examples of innovation. We don't get diffusion, we don't get scaling, and in the Productivity Commission report, interim reports last month, it was identified that for sectors like health, it's government regulation and funding, where government regulation and funding have a heavy influence that stops this innovation from spreading. Michael's talked about an authorising environment. How do we balance that need for flexibility locally with that accountability to, essentially the taxpayer dollar, I suppose, to affect these changes to the way we deliver care? And that's not just for you, Michael, any of the panel members, if you'd just like to make a comment on that. Is that balance, I guess?
Well, I might defer to others because I'm the least expert on the panel on that question, but I'd be interested in views on that. Sorry, I should use this. Just apropos of the reference to our interim report, one of the observations we were trying to make, and it was true of innovation in general across the economy, is that we tend as policy makers, perhaps as people, to put a lot of focus on cutting edge invention, the shiny new thing. In fact, in economic terms, by far the biggest dividend really comes from the adoption, and often the adoption of pretty prosaic, technology or other things, practices. That's right. And but getting them. So we talk about the innovation by the 98%, not the 2% who are the cutting edge global innovators, but everybody else. But noting in the public sector, it's even harder than that because the incentives just don't always align. There's a rigidity set up by a funding model. There's a rigidity set up by those highly vertical accountability mechanisms that the minister's going into question time and needs the brief about the ramping story or whatever it is. That's your incentive. And I just kept coming back to a point that. What Gary Sturgis used to make, his time in New South Wales public sector, most of the innovators in the public sector are rule breakers. That's what they do. They break rules, and rightly or wrongly. So that's not very cheerful. So maybe someone else can raise me from my morose thoughts.
A brief crack. So two things that I reflect on is, if we think about scope broadly, we think about skills and competencies, we think about what you're accountable for, and then we think about authorisation or authority. And people often think that that's a regulation or a legislation, but it's lots of things. And that authority can be divisive and perverse because it can be used. Culture can be one of those, and it can be inside professions as well as outside professions, influencing other professions or other groups. And it can be we've just always done it this way. So I think part of the general thing around scope and how we use things better is actually picking apart what that authority space looks like, and having people like Jill, when she was in New South Wales, saying, yeah, we're going to make it happen. Like, you have authority to give authority to change culture, and that's a really big part of that space. So I think it's actually unpicking what's real and what's not real too, because sometimes we become paralysed in the face of ambiguity in some of those changes. I think the other reflection would be what we've learned from COVID is that a lot of it isn't real, and a lot of change is possible, and you can change a regulation in a day. You don't have to wait a year to change something, that you can use data powerfully to work out what is the most appropriate way to do something and to do population-wide things within a jurisdiction or nationally. So I think what we risk at the moment is not learning from something that has been one of our biggest public health emergencies in this country, and using it to change what we're doing and how we do business. Because my observation is that we've regressed to the norm incredibly fast. Apparently pandemic's over, just so you know, and we can just go back to how we did things in 1970, because that's what we've been doing for the last however many years. COVID gave us an opportunity to change things like scope, integrated practice, different models of care, and different models doesn't mean worse care. If I hear one more person say to me, oh, but that was okay because it's a pandemic and it was an emergency, and it was okay to use those other people because, you know, somebody might have died anyway, so it's okay if they got an injection from a student or they got an injection from a paramedic or a physio. Different doesn't mean poorer care, and that's where value comes in. So that's my 2 cents worth.
Look, I mean, and I'm the outlier here because I'm not within the health system, but it seems to me that we have a crisis at our doorstep in terms of workforce now, and maybe, trying to be optimistic, it might be the precipitation that we will have to do something, because the issue is that we did a longitudinal study for people who worked in the care sector in aged care. We surveyed the same cohort 2018, 2019, 2020. And the biggest reason why people left that profession was not because of money, it was because of the culture of the workplace that they worked in. And I think that unless we basically tackle some of those really big issues now, and of which funding is a part of, then I think there just won't be people who are in the caring workforce at all levels. And so we'll be forced to change, not by a pandemic, but because there will be not enough people in the workforce. And we can't say we're going to import them, because, internationally, the same problem exists everywhere. So, and you know what? If I have a qualification, I can be a permanent resident in Canada in 4 days. If I want to be a permanent resident in Australia, well, number one, that's a whole nother question, but to be a temporary migrant in Australia is going to take me 74 forms and probably about 8 months.
So, two things have been raised just there, among many: culture and leadership. Whose leadership do we need, and how do governments resource that?
You can go first.
I think leadership is at all levels. Clinicians who are close to the coalface often hear from their patients, and we've heard several examples today about that, about new ideas or changes to practice. The Launceston example is a good one, how you engage with the service users, and that's good, but then someone needs to back them in, and then you need to get the ear of people who have the budget purse strings or have access to innovation funds. And in Australia, that's very difficult. I had the privilege of being in the United States on a Harkness Fellowship for 12 months and seeing a different culture there in terms of what fosters innovation, and they have innovation dedicated funding. And we don't have anything like that in Australia. We can go to research, but that's very competitive, and often the timescales are tight, and often they're not funding health systems, which is really what we like. We need to improve on the integration work as a systems piece. It's much easier to get a randomised controlled trial funded. So I don't see as a clinician leader who's looking currently for funds to implement new programs, ready sources of innovation funding to get integration and workforce pilots off the ground. So it's a really tricky environment. So as much as we can be advocating as clinical leaders, we do need to have some avenue to bring good ideas to the table, and that requires senior leadership, probably at a ministerial level.
Did anyone else want to comment on that one? I'm happy to take
Can I actually make a
questions or
comment
comments?
based on
Yeah,
my
please.
name's been taken in vain?
You're getting fingered for a lot of stuff.
I am
actually,
fingered.
sorry.
Yes. Look, can I say from this point of view, I mean, I spent ages working, getting to understand the health. I'm not a practitioner. It took me a long time to develop the network and the contacts within the health system, 14 years in fact. I could never have done the things that I did and some of the really risky strategies that I took, and I name on them, in a policy we released in 2012, the year after I became the minister, to virtually end the transmission of HIV by the year 2020. Everyone gasped and said, how can you put a policy out like that? It was based on science, the evidence that it could be done, the willing participant of clinicians across the board. You know, didn't matter what discipline they were, people in the community organisations, patients, the whole lot. And all I was really was the enabler and the funder. Now, the funding, relatively speaking, was not the most important thing. It was a minister who had the guts, I suppose. Yeah. And the reason why this minister had the guts was I was considered very ancient. So I didn't have... well, no. There was a particular journalist who used to advertise how old I was every birthday. So in the end, I used to go overseas for my birthday. But anyway, the point is that I didn't have any ambition to be the Premier or anything else except the world's best health minister. And if you approach your job with that sort of attitude, that's all you want. So I was brave enough to do anything, really. If it was based on science, I had fantastic support of people, and including my own personal staff. If I ever needed money, my colleagues on the board here know that's not my real forte, it's not my strength. But I had a chief of staff, and I used to say to him, Andrew, march down please to the Premier, the Treasurer's office, have a little word with them. We need the dynamite approach. And he always came back with extra money. So you've got to have those kind of people who are very persuasive, good economists, etc. So it's a team effort, is what I'm saying. It's not just one person.
I'm here on behalf of the National Rural Health Alliance. I just think the population in general is getting to the stage where they're sick of weasel words.
Yeah.
And I don't want to sit here going, oh, well, we're sick of it. because we actually need to do something. And what it actually requires, when we're speaking about leadership at all the different levels, is enough people being, and excuse my language, being pissed off to actually get back together and go, okay, that person has the right attitude. They might not have everything we need, but they have the right attitude. And you've actually got, and I'm sorry I don't know everybody, but you've actually got 3, for example, sitting at the front, and they may not work in the same sector, but they might go, you know what, I've worked in this area, I've worked in that area, and I think I have all the contacts that are going to get this idea across. Because, so I'll use Michael as an example. Michael understands different sectors in Tasmania, and he understands the impact that it has on workforce, on health, on community, on the different clinicians or the health workforce and the politician. We know how that system works. And I think what needs to be done to make some of those changes is to actually get people that might not work in a particular sector, but actually say, okay, I believe in this enough, and workforce might be the area. We're going to get together and actually now advocate, and we will bring our stakeholders with us to make this work. And it might just be one area, because people are sick of pilots. The community is sick of pilots. They're sick of a release because we know there's going to be an election coming up in Victoria. They're just tired of it, and they're exhausted because it's now affecting not only their own pocket, but it's affecting them believing that politicians are actually going to do something, and the entities. And unfortunately, you will have more and more people going, we're not going to be part of it anymore. And that's why we've had all those independents come in. Because, and so I'm not giving you an answer, but I'm just saying it just needs to be pulled together for one particular area to show that you can do it. I'm sorry to not have an answer, but I think that's the only way we'll do it.
Thanks, Susie. Does anyone on the panel want to respond to?
But isn't part of the issue also, though, that we do these pilots and then there is no evaluation of what exactly is the public health outcomes as a result of them? It's just activity for the sake of activity. And I think that's where I get frustrated when you see how much money gets spent on establishing a new entity to have a different, and I can name a whole heap that I think are probably going to disappear by the end of this year because their funding will stop. And yet, you know, so it's not about money, because there is money to do things, but it's just not driven by, you know, by what's the public health outcome that you're trying to achieve. And that just doesn't seem to factor into the evaluation.
I think it's a bit sadder than that. I think with most pilot and trial funding, there's a contractual condition for evaluation. And you present the report that says this many people were helped in New Norfolk through a collaboration between the Royal Hobart Hospital, the local GPs and the Primary Health Network. And we've even been able to demonstrate the number of hospital admissions that were avoided as a result of this particular program.
Goes in the bottom drawer.
And the money ran out. And so that program stopped. Those people had to find themselves other jobs. The tech, which was pretty basic, was returned to where it came, or it was sold on Gumtree. I can't even remember now. The point is that when, as a nation, when we decide that we're going to trial a drug, there is a pathway for that drug to go into distribution, into pharmacy, into hospitals or wherever. But with services, there is no pathway at the end of it. And so until such time as we re-engineer that system such that, you know, what's the problem we're trying to fix? Let's do a trial, let's do a smart trial, and let's have a pathway built into this such that if it's demonstrated to have benefit, then it goes into the system either, you know, through Commonwealth or state or PHN, LHN funding, they're all technical things you can sort out down the track, but it has to have a pathway whereby the success can be maintained. Because there's nothing worse than seeing people whose life is improved from being pretty lousy.
Yep.
And trust me, the portfolios I've heard in Tasmania aren't the subject of polite conversation in terms of the lives some people have to live. And you work with them and you lift them up, and then the money runs out and you go, sorry, you're stuck with your GP. And that's it. And GPs are very busy. If they're really unlucky, they've been bought out by a corporate. Sorry, corporates, if they're in here. And they're down to the timer on the phone in front of them, so they can't spend a long time with a mental health patient. All of these things compound, and you watch them slip away again and turn up back in the ED where you found them. Just to take the discussion totally out of health, because to me, I think this comes to what are we calling value, and I'm not advocating that we do art projects, but this was an art project. So I've got a poster of this thing in my office. It was a play, and the play was called A Cat Called Bird, and the poster features a picture of a dog. So it was an Arts Australia grant, and it involved 18 men who were 40 years and over, and who were, oh, it's a terrible thing to say, frequent flyers. They were frequent presenters at the emergency department at the Royal Hobart. And they were gathered together under an organisation called Kickstart Arts. They wrote the play, and it was about living with mental illness. They wrote the play, they made the props and the costumes, they produced it. It was a project that went on for 18 months. Interestingly, what you observe is that every day of the week, if they wanted to, they didn't have to turn up every day, but every day they all had somewhere to go, they had something productive to do. They were in a community. Some may even call it a home. There was no clinical involvement with this group at all. They were literally employed, for want of a better phrase, with a theatre arts company. For those 18 months, none of those men presented at the ED. The numbers around what that saved and the admissions it avoided are pretty horrific, because that's not the service they needed. That's the service that we were funded to deliver, but that's clearly not what they needed. So in terms of value, it does go to quality of life, and that's why the consumer voice in this is absolutely critical. And I was so glad when someone raised Aboriginal people earlier, because what they regard as a high value outcome won't be what a cardiologist thinks is a high value outcome, who from personal experience will see a person as a life support mechanism for a heart. So, you know, we've got to rethink what we're doing with this group of people. I think ABF is fantastic for something that's short-term, runs a standard course, and has a kind of neat beginning and a middle and an end. Yeah, it needs fixing. My daughter's broken leg. That was an absolute classic. And she was in, she was out, you know, cast to boot and all that sort of stuff. No drama, no soliloquy or anything like that. It was all very straightforward. But for these people, particularly if one of their chronic conditions is a mental health condition, they need a whole different approach. And I think we just have to be very broad in our thinking about that approach. And it requires pirates. We say rule breakers and people that push the boundaries. It's people that are more pirate than navy, and are going to take those risks outside the rules and bend them as far as they can, because there's a demonstrable benefit to human beings at the end of it. I seem to be sitting on a soapbox.
Yeah. but it's also there has to be sustainability.
Yes.
That's the problem.
Yep.
That's the problem. It happens, but we just then it dies,
Yeah.
and it doesn't just get populated. I have a daughter with a disability, and one of the biggest learnings for me, we eventually, after many years, eventually got her into the NDIS system. One of the challenges, and I made the fatal mistake of saying, well, what you need is, we need to get you a support worker, and, we'll choose who it's going to be. And, so I came up with all of these people, here's an enrolled nurse, and here's this, and there's this. And, and there was complete disengagement from her. And And it was her partner who said to her, well, what do you want? And she said, I don't want somebody who's going to come in and basically control my life. I want someone who's going to help me, and I want somebody who I feel comfortable with. And I don't want them to do those things. I want them to do something different. And so what the person that she chose is completely different to what I thought she needed. And I think, and you know, I'm someone who believes in consumer-directed care and self-management, and I think this is what we too much do to people instead of listening to what people want. And the problem is what people want is not homogenous, and that's the challenge. Because it's not homogenous, that is where, from a system point of view, there's the challenge. We want, you know, someone who's a worker to have exactly the same job and outcome, when that's just not the reality of the system. What a nurse does in Northern Territory is very different from what they do in CBD Sydney, because they're operating in a different environment, and you know, it's complex. And unless we have a funding system that recognises how much complexity there is and has the flexibility in it, we're going to continually trying to put square pegs in round holes.
Yeah, thanks, Yasmin. Lisa.
No, I think your point's fabulous about having the model to support things. And I think some of the challenges that my pharmacy had on for my first comment about, like, we do PBS evaluation, right? And we look at a lot of the medicines that get onto the PBS that have had trials in 200 people. And then you go to Michael's point that we trial grade programs that we might do in a lot more people than that get piloted and shelved. And we spend millions of dollars on drugs that are going to help 200 people. I'm not saying that's like I'm wearing my pharmacist hat, I declare my conflict of interest, but that's okay, 200 people, millions of dollars. There's a mechanism to do that, but we don't have a system. So, and it's because it's not homogenous, it's not as straightforward. But what we continue to do, and we experienced this a little bit when we were rolling out pharmacist vaccination, is we would come to speak to people about the data we had, which we got $10,000 funding for total. A lot of free help. But people in South Australia are different to people in Queensland. Oh, well, apparently 31,000 of them were fine across the state, in regional and rural, of different ages and different demographics. And no, we'll have to pilot it here as well. Yeah. Okay. So you run a pilot. Oh, we got the same answer that you did. Whereas other folk, Pirate Pete down here, rip the Band-Aid off and say, well, that seems reasonable, let's have a crack at that. And so we continue to say, well, people in New South Wales are different to Queensland. Well, Queenslanders know that, but I think we continue.
So New South Welshman.
Correct. State of origin time, particularly. But I think we continue to say, but my person is different. And while we have a homogenous system, and systems in Northern Territory are different to metropolitan Brisbane, I appreciate that. We use that as a weaponised thing.
Yeah.
And we say we can't do that because I'm different in the south of the river than the north of the river. Well, my hospital's super special and it's really different to your hospital. And I think we have to stop doing that. And we have to have a way of evaluating the types of services with some of the characteristics of the PBS, but not exactly the same.
Do clinicians want this? Do you think? Are they ready for this? On the back of a pandemic, are they also ready to take on such change in their roles?
I think they're sad and crying at the moment. But my reflection from colleagues is they're burnt out. They are sad about the workforce and as you said, what's their career journey? What does that trajectory look like? Who's coming to support me? How am I going to get help? How do we get different models of care? I want to do things differently, but I don't know how that's going to happen. So I think my general reflection, and particularly looking at students coming into the workforce, is some dismay. We spend a lot of time going, career ahead of you, it's brilliant, look at the scopes you're going to do, top of scope, woo! And then they kind of get out there and clinicians are like, it's horrible. Get out if you can. And we're like, no, don't listen to them. They're sad and bitter. You know, they've had a pandemic. It's okay. It'll be fine. but it's not. You know, it's not. They are under pressure, and there are more and more people leaving the workforce. They're becoming part-time, or they're silently retiring.
Yeah.
They're just not going back. Oh, I was going to take some time off. Oh, what happened to Jan? She went on holiday 6 weeks ago, never came back. So I think that is the vibe, and I'm sure there's others in the room that would reflect similarly. And so I think they want some kind of way, because I think at the heart of hearts, people went into this to help people and people in their community, and they wanted to be able to do that with the skills that they trained for, and we use a small proportion of what those are, regardless of who you are.
Can I ask, how do you increase the Aboriginal health workforce? Your answer to that. I'm on another board with that desperate issue.
Indigenous health.
Do you want to go with that? I can go.
No, you go.
Well, what Aboriginal communities say is they want training on country.
Yep, exactly.
That was the false step in late 1980s, early 1990s, where overnight the apprenticeship model, where Aboriginal clinicians worked in their community with all their cultural knowledge and language skills and ability, know-how to get things done, that was of high value. That became instantly devalued the moment they decentralised training or ripped students out. So in the community I visit every week, we've got 5 exceptional young adults in their 20s. They've been down south, so there's a social contract in the community to make great sacrifices to get them an ATAS score, and then come back to community and there's no pathway for them. So we've reneged on our social contract with those families that have invested greatly through very painful, in absolute poverty, to get their kids an education. And the model is they have to leave their community, travel hundreds of kilometres away, be unsafe, leave their young children to attain any skills. And it doesn't work. We've seen it now for 20 years. So we need to take the hard decisions. We need to invest in on country or in community education, and then workplace mentorship. And these 4 young adults in my community, they could run the show in 10 years. They're all, whip smart, very capable young people, but the light's slowly fading in their eyes.
Yeah. And look, and part of that is because, and I'll give you an example, in Queensland TAFE has got even classrooms in community, and there's certainly there's a local hospital where they could be trained in community, but instead, because it's all about their delivery model, TAFE requires everybody in Queensland to go to Cairns to train, right? So that immediately cuts out a large number of people who don't want to go to Cairns, and then those who do, often, basically because they've got no support and mentorship there, will, don't complete, drift off, etc. So, again, it's who's the system for, right? Is it to suit TAFE's business model, or is the desired outcome to train basically Aboriginal health workers in community?
Just got a question from Tessa.
Thanks so much, Tessa Woodcote again. Lisa, your comment about homogenisation and difference and how are we accounting for that really sort of reminded me of that challenge around innovation. Well, in the social policy space, the kind of idea that innovation is at the opposite end of best practice. And that's something that we come up against a lot. We're kind of translating between health and social policy, and we've got examples of innovation in how services are delivered, how services are partnering across silos, non-health staff in health settings to bridge a lot of those health inequity issues we've heard. And then we're talking about the approach, and the question is, so what's the best practice model? And actually that's not a good fit for innovation. In fact, it really stifles it. But what we are seeing is the kind of elements of place-based that take account of not just absolutely start from different community need, but take account of different service responses, different service infrastructure in community. So I guess I'm interested in, I think the conversation's almost already moving there anyway, I'm interested in the panel's kind of reflections about how do we grapple with the national policy challenge around health workforce and the agenda around values-based and better integrated care, and enable that difference at a community level to really lead a person-centred approach?
It's a lot to take on in your comment. Well, can I comment on the thing about innovation and evidence? I think some of the challenge that we find too is whose voice we want to believe. And the thing I've found in some of our work and research is the consumer-based care model or patient-based care, and we want to found our services on co-design, and the actual what that means and what consumers that we work with, even from consumer organisations who may be more informed or health literate perhaps than others, they're not even sure specifically about what that is. And then you've got a whole group of clinicians that I think, as you pointed out, you know, the body supports structurally the heart. And so we haven't necessarily got a clinical workforce who understand what we're trying to achieve around those things. And so we come up against situations where evidence, which is different to what our classic evidence might be that we're used to as clinicians, is presented by consumers and non-health people, and it's dismissed or it's recreated or done again because I can't believe that because I didn't do it. So I think there's a whole pile of things from a workforce point of view, from health, that we need to wrap our arms around, a whole pile of other ways of doing business. We have to educate students as they're emerging into this. And I think, you know, we're making assumptions that the people we're trying to help know what we're trying to get them to help us with as well. And I think that's a whole other piece of work. Because designing a system in your space, social justice space, in hospitals and others, and saying, what system do you want? And they don't even necessarily understand that there are two systems, acute and, well, there's more than that, but acute and primary care, and how that works and where the funding comes from, and why do I have to do a copay when I go to the doctor when we've got Medicare? And why don't they ask me about private? And what's a generic? Like, they don't necessarily understand the system we're asking them to redesign. So I think there's a whole pile of other work that sits in this as a horizontal, vertical mismatch, because what we're trying to achieve is complicated.
Yeah, I'll just make one observation about a theme that's been a bit of a recurrent theme that I think goes to your question, Tessa. It's this. There is this question about how does service innovation look different to, in the health context, like molecular innovation, right? And how do you deal with heterogeneity? Okay, so Lisa's point's right. There is a bit of sort of cute kind of attempts in instances like pharmaceuticals to sort of say, oh, well, it's going to, you know, it works for Queenslanders, not South Australians. And in that instance, yeah, if there's been a randomised trial, you've got a pretty good sense, depending on sample size, but pretty good sense of what the average treatment effect is. You don't know the impact on individuals, of course. That's one thing about, you know, all these pharmaceutical innovations. You're getting an average treatment effect. There's no guarantees around the individual effect. But yeah, reasonably replicable, you would think. But service innovation isn't like that. I mean, there is a sense in which if something was tried and done successfully on the Gold Coast, it may not work in Adelaide. But certainly if somebody starts out with the mindset of, oh, that's not going to work here, well, I can guarantee it's not going to work here if that's the mindset. So there is a point to me about, you know, we have to be a little clearer about what are the sorts of things that can drive service innovation as distinct from, you know, I'll call it the sort of scientific innovation. I think it's a good point that we, through funding means, NHMRC, all that stuff, it's very much around the kind of medical research. Let's get the breakthrough. Let's be in league with, you know, the frontier, people doing work at Harvard and all that sort of thing. Well, where's the commitment to some genuine service innovation? But I guess the challenge is that, yeah, you might, it goes to the pilot point, you might get some good models, you might get some things that are shown to work. You've got to understand the differences, and you can't, so I think RCTs even, you've got to be a little realistic about what's possible in a social policy setting vis-a-vis an RCT. I think it's, you know, we're the sort of great advocates for robust evaluation, but don't always think an RCT is the gold standard, it's got to be that. You know, often what matters in an intervention is, does somebody own it, are they willing to drive it, you know, and it's not this idea of it's tried here, it's therefore replicable over there. So I think that you know, the service innovations are a bit different. We need to understand that, and you need to go into it with a bit of a mindset of it's not going to work in exactly the same way in a different setting. So yeah, there's heterogeneity.
Thanks. And sorry, my comment is going to go to Jim's earlier question about how to grow the Aboriginal health workforce. And I just wanted to point to the work of Indigenous Allied Health Australia, who have an academy model that picks up students in middle high school and coaches them through to complete GHSC. So these are Aboriginal and Torres Strait Islander students. And as part of the HSC, they complete a certificate through in allied health assistance, so that they're graduating school with a qualification, and IHA help them then to find work in health organisations. So it's culturally safe. It is something that IHA devised themselves, funded themselves initially, and it is now receiving Commonwealth funding to support the growth of that model elsewhere. A lot of those students go on to study in allied health programs, and many of those students transfer into medicine. So it's a fantastic model that just shows the strength of community-led solutions to workforce. I just thought that I wanted to raise that. Thank you.
The workforce, can I tell you the location for the Aboriginal health workforce? I'm talking about the prison health system. It is giving you at all be aware of the very high proportion of Aboriginal people in custody and the very, very poor level of Aboriginal health workforce. It's a real problem. So it's, you know, training in place. That's what we're starting to do, training in place. It's absolutely the only way, but it's complicated.
Tony, up the back.
Thanks, Kylie. I'm Tony Lawler, I'm the Chief Medical Officer in Tasmania. It's amazing to me how many of these seemingly different things are also interrelated.
Yeah.
Pull one thread and multiple tapestries fall apart. But one of the interesting things for me is the myth of fingerprints, which is this: we're all amazingly different. And it may surprise you to hear that Tasmania feels that from time to time. One of the things I've found is that unwillingness to accept something that's happened elsewhere, unless it's repiloted and reassessed and retried, doesn't seem to be a problem if people want to do the new thing.
Yeah.
And funnily enough, it's completely plausible if people want to implement it. And so a lot of the time it's about risk, and risk is used as an excuse. And Lisa, there's a couple of things I wouldn't mind just not picking apart, teasing apart. Is that's the same thing. I appreciate that.
This is Kevlar, it's fine.
You mentioned how quickly and I think how sadly we have reverted to type following the pandemic. And I was a bit puzzled about why that happened as well. My involvement was around hospital response. And I think if you instead of looking at it from the focus being on outcomes, the focus is always on risk and the risk that we prioritise, I think that actually kind of explains exactly why it is. Risks were taken during the pandemic that we wouldn't normally take. Disease prevention was prioritised above financial stringency. And I agree with you that having one group do something that another group traditionally does is not the end of the world, and it's not a detriment in quality of care provision. But a lot of people don't view it that way, and they see that as a risk that they are taking, and when other risks are deprioritised, then that risk is a risk that's willing to be taken. We have completely moved back to the other way. With COVID funding about to dry up, with MKs about to cease, all of a sudden the financial and the operational risks are reprioritised, and so we go back into a comfortable space. And I think that's the challenge that we need to think. In terms of the workforce change, I find the discussion around top of scope really interesting. It's extension of scope or enhancement of scope. We're looking at people doing more things than they used to do when we have a finite, and in many places shrinking workforce. And I find the challenge is not around getting people to understand how they can enhance their scope and do more. It's actually around surrendering some of the things that other groups can do.
Yeah.
How do we address that? How do we actually get people to move to the right or move to the up and vacate a space for other people that want to be in that space?
Yeah, no, two great points. So much to unpack about COVID. Things I noted implementing the COVID program and some of the big experience I had was doing the First Nations vax rollout through Queensland, and some of the big things that melted away in some of that were funding. So you're right, as you start to remove funding, and we weren't coming to the table with PHNs and NATO and Quake and the HHSs and everybody coming to the table and going, okay, what are we trying to do today here? And everybody going, well, I'm going to bring this and I'm going to bring this, because it didn't matter. People just said, well, this is an outcome, and money kind of didn't come into it. It wasn't like, well, who's going to pay me for this? And it just didn't matter. And the other thing was authority. So normally it would take weeks to get the minister to sign off on something, sorry Jill, or to go through the CLO or the SLO or whatever. That was delegated to somebody else. So, and that didn't just happen in the big office, it happened through all of the system. That there was delegation to somebody else who had authority to do things. And so I think those people who were probably risk takers were the pirates, were the people that wanted to innovate, that wanted to lean in. They felt really awful when it ended. They're like, oh, we're going to go back to waiting 6 weeks to get a sign-off to get a new post-it pad. This is awful, where I've set up a mass vax clinic in 24 hours. So I think they're 2 points that I noted. With regard to the scope, I think you're right. I think we're using a very small proportion of actually what we train health professionals for. So it's not always expanding. I think of it like a belt. Like we've got lots of holes on our belt. When we graduate somebody, we graduate people with a particular competency set or an expectation for a threshold graduate. And then we use less of those holes, mostly, for most of our workforce. And so what we often try and do is get them to use all the holes. And sometimes we identify that we could punch a couple in a risk framework. And so adding vax to pharmacy initially was punching a hole, because we punch a needle into people's arms because we don't touch people. So we had to literally do the touching bit. But now graduates come out with that. They've got the hole in their belt. So I think part of it is we don't let go of stuff, because often we're afraid that if we let go, somebody will take something else. And we don't know who that might be, because we can't see that there's something that we can actually contribute to in the future. And I think that's where teams working together, the opportunity to say what's best for the patient instead of fighting for the chips on the ground, allows people to release other activities. So pharmacy is a great example. We've got God knows how many, I think probably 30 or 40,000 last time, Kylie, we ever did any maths on it, assistants and technicians. We don't use them properly. They do some stuff out in community pharmacy perspective. There's no regulation or real framework to support that. Pharmacists go, well, if I let them do dispensing, what would I do? Everything else. Everything else. Because we haven't let them use the holes on their belt. So I'm holding onto those holes just in case somebody else takes those holes. So I think that's part of the problem. Sorry for the big answer.
No, that's good. Michael.
Just quickly, as one of those gatekeepers, as a head of agency, I often tell people that the first 6 months of COVID were like working without adult supervision. Yes. Just fabulous. The risks that we took that were measured, I mean, we weren't stupid, but the things that we did that we would never have been allowed to do otherwise, because, you know, oh, what happens if it ends up on page 3 of the Mercury? Heaven forbid. And I won't, we're going to run out of time, but the results were just amazing. And even up to and including Treasury lifting all the Treasury's instructions around procurement and employment and all those things that get bogged down, so we could respond much faster. And then, of course, a politician, not a chief medical officer or a chief health officer, decided that COVID was over, and all of those regs and things all got put back in place. Part of, and I think the word was used a couple of times about us collectively, you know, the whole system, falling back to what was comfortable. I think part of how we stop that is to make it uncomfortable to go backwards. So in particular, a couple of the things that we did with child protection and family services was to make it to make sure that people knew what had worked and produced outstandingly better and in almost every case cheaper outcomes, such that it was very uncomfortable for them for government to turn around and go, well, we really don't like this because we've not done this before, and it's making the status quo uncomfortable. And you can. Tony Blair did all of his disruptive technology stuff, and that's all pretty shiny now, as is Tony Blair. But there's a point to it. And Tessa, there's a great article called "The Truth About Best Practice" by Jacques Fitzens, who coined the phrase best practice. And actually the whole thing is about how he regrets ever saying it, because it's weaponised.
Yeah.
And you can't do that because it's not best practice. Best practice is contextual. Best practice in an Indigenous community in the Northern Territory will not be best practice in downtown Hobart. It's about the context, it's about the skills that you bring and the resources you've got. Thank you. Sorry.
Just one really quick observation. It's a fascinating thing when you look across the board at post-COVID, what has stuck and what hasn't. So we're observing a bit of snapback in relation to this, but not everything's like that, right? So remote working, that's kind of here to stay in a way that's, we're not going back to 2019 on that. Online retail, probably similar. I think maybe jury's out on telehealth, but I suspect it's going to stabilise at a higher level. And even on some of the regulatory stuff, in fairness to New South Wales as a jurisdiction, they commissioned a bit of work on not so much on the health stuff specifically, but the other regulations that were relaxed, including delivery times for goods at supermarkets and all that sort of thing. They did a robust sort of exercise in terms of, well, what should we retain? We got rid of a lot of this stuff, partly specifically because it was necessary to make sure the toilet paper was in the supermarket, but partly probably with a view that we were going to regulate a whole lot of other activities. So what can we get rid of over here at the same time? And some of it's worth retaining. Some of it we should learn from it. So it kind of is interesting to ponder what characterises the things where we've snapped back, what characterises the things where we've some behaviours have stuck.
Great. We're running out of time, but I am going to give you the chance to say one more thing. What's our key takeaway? Lisa, you've just taken up the microphone, so you can go first.
Yeah. Well, a key takeaway, and I'll just reflect on the COVID, is there's collateral consequences if we don't do something. And the COVID journey, my greatest sadness, having put all of this process in place, we worked with the First Nations health workers to enable them to vaccinate. Our vax rates went up because they were vaccinating trusted people in community at the place where people wanted to get vaccinated. Queensland was in a pickle. We were at a point where we were going to have thousands of our First Nations people die once the borders opened. It was looking catastrophic, right? And we changed it so that could happen. Now that COVID's over, we took it away. So we now have to try and fix that. Pharmacists could vaccinate in arches, they could go out into aged care, they could help vaccination programs in schools. Not anymore. So pharmacists, while they've done 10 million COVID vaccines across the community, did a lot of those outside of community pharmacies. Not anymore. We're back in a building. Pharmacists are now building again. So we now have to go back to consulting on those scopes of practice, putting in place the legislation regulation, and I think that is horrible, particularly for our health workers, and we need to do something seriously about it quickly. So I think we can't go back. We have to go forward.
Paul.
Thanks, Guy. I've been reflecting on your question about clinicians before, and I think, yes, there are people transitioning away, and I think my perspective on that is because they feel things going back to how they were in 2019. Because we saw what was possible when all of a sudden the guardrails were removed and we could talk to people, form alliances, integrate with services that we had turf wars with previously or were regulated out of cooperation through whatever structures, governments or politics. And then so much was possible so quickly, and it was the best time for clinicians, and as a public health physician in the thick of a COVID response, there couldn't be anything better. But now we do see this, that like the opportunity disappearing, there's some of us who are saying we need another pandemic, we need something else to bring us together, and perhaps that's it. We need to think about bringing all those skill sets together, integrating to solve some big problems actually. Chronic conditions is a big one, but doesn't have the same gravitas that a pandemic does. But certainly for us, that's the major killer. 80% of the gap in life expectancy is, for our First Nations, is chronic conditions, and we don't have a similar coordinated, integrated, energetic response to removing and thinking whole of systems through food supply and clinical systems and models of care. We don't see the same level of urgency, and I think that's what makes us tired, because we see so much appetite for innovation from consumers, from clinicians, and then it's just getting blocked. And that's what makes people walk away.
Biggest takeaway for me, I think, is we've got to somehow find a way to break patch protection, which is about culture, and I think funding enforces that patch protection, and somehow we've got to look at how, and I think that as an organisation, AHA is actually well placed to be, because we represent such a breadth of membership, an opportunity to bring a cohesive voice about how you can do things differently, and that it isn't the end of it doesn't mean that because somebody else is doing that role, that means your role's redundant. Actually, it's going to mean that your role's going to be better because you'll actually be doing what you're trained to do. But it's how we manage that fear and that protection mechanism that seems to be endemic in the health sector.
I think the takeaway for me is a worry that the public memory is very short, and that with the exception of the people in this room, far too many people will forget what happened, especially during those first 6 months, what was achieved, how effective it was. And I think it's on all of us to make sure that these results, these outcomes, these learnings are recorded and promoted heavily such that people don't forget it. Before ABF came in, South Australia had a fantastic chronic disease management program, but with the new funding model and the split between local hospital and primary health networks, that was lost, and they have access block. They've had access block problems ever since. Victoria, of course, had a magnificent hospital admission risk program going for many years, and that also lost its funding. And unfortunately, there's not many of us around who remember these things and remember the benefits they have, not just for patients and communities, but for budgets, for treasuries, for government. And so I think what we need to do is to start gathering and continually promoting the benefits of the alternative. Otherwise, it's too easy for them to not listen, and after a while people stop raising it and stop reminding them of what was achieved in Queensland, until, of course, the next crisis comes along when we have to learn it all again, because people have moved on, because the heads around the, I've forgotten what they call it now, the heads of health, I think, table have all changed again, and it's all new for them. But the system should be able to remember.
Michael, I hope your takeaway is everything that's been said for the final re-inquiry.
Yeah. My takeaway is I've learned a great deal, so it's been great. Look, I guess one bit of perspective is that the system is not all bad, right? There are a lot of things to like about the Australian system, and it's producing good results on a whole lot of dimensions. It's a pretty good adopter of technology where there's a conveyor belt there, like a PBS or a listing process or whatever. It's just not a great innovator where there's not an existing conveyor belt. And so I guess the sort of twin doubts that one would have is, probably three doubts. One is, will it deliver equity? Because it is a bit one size fits all. It's not going to, ABF, fee for service, all that stuff's just not going to deliver in a remote Aboriginal community. Point one. Point two, will it deliver for chronic disease? And that's becoming an increasingly important thing, and I think the answer is it's not. And my earlier point, is it well equipped to kind of drive the sort of productivity gains, whether that's through increased quality or reduced cost through adoption of either service innovations or technology? I just think we are just up against that thing that, yeah, it's the pirates. That's my takeaway. It's not about pilot programs, it's about pirate programs.
Very good.
Thanking our panellists and Michael. And I will just end to say that we have on record that we did say everyone is a leader. So we want to be here to share your successes, share your experiences. Please stay in touch. We have some gifts for our speakers. Thank you.
While you're doing that, Cully, can I ask if we collect, I'm wearing my AJJ hat, if we put together a proposal to develop a pathway, building on the learnings that have been, the lessons that we've learned today and everyone else in the room, could that be turned into the Deeble Institute, into some kind of paper that can try and help lead the advocacy we might put to the decision makers about developing a pathway forward that doesn't lose the things that we learned through our response to COVID? Would people participate in that?
Sure.
Putting on the line.
Excellent. We certainly have intentions to have a discussion. If I could get you all put your hands together and thank Michael.